A very good evening to all the delegates and panel members. I'm Dr. Yogesh, working as Senior Medical Advisor at Abbott. On behalf of Abbott and Indian Rheumatology Association, it is my pleasure to welcome you all to the first program of Grand Rounds in Rheumatology, wherein the first topic of today's presentation is axial spondyloarthritis. We are delighted to collaborate with Indian Rheumatology Association under the banner of IRA eConnect. And IRA is an esteemed body that works towards advancement of rheumatology in India. And today's program is a testament to our shared dedication to enhancing the understanding and management of axial spondyloarthritis, a condition that significantly impacts the lives of many patients in India. We have assembled an expert panel today who will share their invaluable insights and research experience to all the delegates. We encourage you to engage in this program through the session, through chat box. You can put up your questions, you can share your thoughts throughout the presentation and during the panel discussion. We hope you find this program very informative and enriching. Moving on, I would like to express my gratitude to Team IRA eConnect, where we had reached out for support and collaboration from the Team IRA eConnect. And moving on to the panel for today's discussion and presentation, we have the moderator, Professor Vinod Ravindran, who is working as a consultant rheumatologist at Center for Rheumatology, and he's also working as an adjunct professor of medicine at KMC Manipal. He's also works as a secretary at IRA, and he's also co-editor for Rheumatology Oxford. He has been awarded with multiple accolades. To name a few, it's IRA Oration of 2023, and he has published more than 200 articles and 30 book chapters. We welcome you, Professor Vinod.
Thank you.
We have our esteemed panel, we have Indian speaker, Dr. Bimlesh Pandey, who is working as a chief consultant and head of the Department of Clinical Rheumatology at Fortis, Noida. He's also been the past executive committee member of Indian Rheumatology Association. He has delivered not more than 75 plus national, regional, and international conferences, and he has a keen interest in conducting clinical research and has been part of 8 clinical trials. Moving on, our international speaker, we have Professor Nigil Haroon. He is the past president of Canadian Rheumatology Association and is presently working as the head of the Division of Rheumatology at the University of Health Network and Sinai Health. He leads translational research program in axial spondyloarthritis and has established the first pan-Canadian clinical trials network. He's been honored with multiple accolades. To name a few, it's Jan Bruckel Award and the Young Investigator Award by Canada. He serves on the editorial board for 4 journals, and he's been keen and instrumental in formulating multiple guidelines for spondyloarthritis. He has contributed to 7 books and published more than 115 articles in the index journals. We welcome you, Dr. Nigil Haroon. So in a snapshot, this is how the agenda looks like. We have the Indian speaker, Dr. Bimlesh Pandey, setting the tone for today's presentation with a topic named as Unmet Needs in Axial SpA in Real World Practice, which would be for 15 minutes. And we have the international speaker, Dr. Nigil Haroon, giving us insights on exploring therapeutic targets in axial SpA, wherein he would share the current insights and future direction. And we would then move to panel discussion moderated by Professor Vinod, and then the vote of thanks. So as part of, and now we move to our very the President of Indian Rheumatology Association, Dr. Chandrasekhar's address. So over to you, Dr. Chandrasekhar. Dr. Chandrasekhar, you can
unmute. Good evening. At the outset, I welcome all the panelists in the board, as well as all the delegates who are going to be enriched by the lectures that's going to follow. I think this is the second in the series of our new IRA with reference to eConnect. The first we had with young researchers to be followed now being addressed by a senior researcher who has really done a lot of job with reference to spondyloarthropathy. I think it's the time we look into the each and every aspects, keep learning, and that's what is the motto of all of us, and as well as it's one of the main agenda with which the IRA is organizing these programs, which we are hoping to have it at least once a month or once in 2 months. I think with this brief note, I welcome all of you to be a part of this endeavor. Over to you, Dr. Vinod.
Thank you. Good evening, everyone. The IRA fraternity here, and I'm aware that people have joined from other countries also. So at the outset, I would like to thank our president, Dr. Chandrasekhara, for allowing this combination or this association to work. IRA eConnect was up and running for the last 2 to 3 years, and we have made some changes. And you already met our team. This is actually so we've done 2 programs before that, and this is the first one where we have associated with Abbott for this series of grand rounds in rheumatology. And so the main talk today from Nigil looks at the therapeutic targets in spondyloarthritis. What are the changes? So as you know that spondyloarthritis is an autoimmune rheumatic disease, which has its own unique challenges wherever you are, whether in India or abroad. With the advent of newer modalities of treatment, newer therapeutic targets, and the recognition that there might be a window of opportunity very similar to rheumatoid arthritis, and the ever expanding awareness or insight into the pathogenesis of spondyloarthritis, there has been a sea change, particularly in the last decade or so. And Nigil has been at the forefront of this research based at Toronto in Canada. And I'm really delighted that he's here to talk about this aspect in the next 35 minutes or so. But before that, we had to consider what are the unmet needs as far as the spondyloarthritis are concerned in India. Dr. Bimlesh is basically a foot soldier of Indian rheumatology, a very senior member, and with lots of hands-on experience in the background of various different geographical areas with unequal economic and social economical scenario he faces in his day-to-day clinical practice. So I think he is the right person to discuss first up the unmet needs as far as spondyloarthritis management and diagnosis and other aspects of this debilitating disease if left untreated is concerned. So with that a brief introduction to what is going to be followed in this session further, I invite Dr. Nigil Haroon to start with his talk. Thank you.
The first presentation would be from
Sorry,
Dr.
yeah,
Bimlesh.
sorry, I missed that. Yeah. I beg your pardon. So yeah, no, we got Dr. Bimlesh Pandey to update on us unmet needs in this particular area. Thank you.
Thank you, Professor Vinod, Ravindran, Secretary IRA, as well as be a great friend for setting the context. I'm also thankful to Dr. Chandrasekhara for able leadership of IRA and the team eConnect, which has given a valid platform to share ideas and what Dr. Chandrasekhara said, learn to share knowledge as well as learn. I start my deliberation. I also thank Abbott for coming up and shaping this program, and Nigil Haroon for the speaker. So the unmet need in axial SpA in real world practice and Indian perspective is important because we are a population of 1.4 billion plus, and that is the gravity of the problem, that we are large in population. And so since the flavor of this month is Olympics, so we always have to see how we deliver. So can we have a perfect 10 for our patients? So the young Nadia as well as the coach Bella, they worked way back to achieve the perfect 10. So can we achieve the perfect 10 for our patients in terms of outcome over a long period of time? It's not an easy job to have a best outcome in a disease which is so, sometimes tricky, sometimes difficult to manage. But before we think of having perfect 10, we need to understand ourselves better as an economy, as a country. So if I say that the average monthly salaries of a young person in India is around 5,900. This brings down the whole equation of patient management in terms of cost effectiveness. And we all know that this disease is a disease of young people. If it is a disease of young people and they are not economically viable, so it becomes too tricky to deal with the situation. So when we have to speak spondyloarthritis, the nihilism associated with prolonged treatment should be subjected to something that we have experienced, we have learned from HIV epidemic in sub-Saharan countries, where a younger population, because they were getting affected by HIV and AIDS, they were dying early, and that was not the best situation to ever happen. So they were not contributing either to the economy. So WHO took a giant step. Multiple collaborations happened with the rich countries, helping the poorer sub-Saharan countries. And you could see that by 2000, the maximum dip had happened, and the countries which were badly affected came out of the situation, which was so taxing. So the taxable population, they survived, so they contributed to the society. They raised the GDP of the country. So if I see as a health economist, I would like to see if someone is affected by this disease, can he be working, and can he be working effectively for himself, his family, his society and country? And that is what is also highlighted by a study done in Australia, the long-term economic impacts of arthritis through lost productivity of life years. And that is something that we need to address in our day-to-day practice. So spondyloarthritis, a disease of younger population, a disease which affects the worst way the young population. Now, what is an advantage? We discussed about the disadvantage of a very poor, we are developing country. We don't have that large income. We have advantage of India being a capital of biopharmaceutical, and the concept of Make in India, Made in India has been in existence in biopharmaceuticals since long, maybe 40 plus years. And that has translated to huge advantage to our population for drugs being very, very cost effective, quite cheap to our patients. So it does not hurt that badly when it comes to what it is in the Western world. Please mind, even the best of these economies cannot sustain the high cost impact of any, treatment, or if the disease burden is too costly. So if I say America owes around $150 billion of medical debt, it highlights the situation. So even if you are rich, you still have to struggle due to a large amount of medical expenditure. So we need to be very, very careful in our selection and in our thought. Now let us see what has happened in last 40 years. The first few research work came from All India Institute of Medical Science, Professor A.N. Malviya and Professor Ashok Kumar, that did a good amount of work, and similar type of work happened in other part of India, chiefly Mumbai and Chennai. This was highlighted in a chapter 30 of Oxford textbook of axial spondyloarthritis, where Professor Malvi and Professor Ashok Kumar contributed to this chapter, the axial spondyloarthritis in India. Now the question is, what was the problem in 1984 in Delhi at AIIMS? What was a similar problem in 2009 and 2014? So if I would highlight, the disease duration was around 8.7 years to begin. In 1984, it went up as high as 9.3 and came down to 7.83. So the disease existed a long time before they were being identified. But something changed, and the thing that changed was male to female ratio. So it was a male-male disease in 1984, 16:1 from male to female. It comes down to 5:1 and then 3.75:1. So now we identify that it is just not a male disease. So something we changed after our observation and basic collection of data. So delay of diagnosis still remained the same. So this is how it was different in early 80s versus 2014. The other contributing chapters like Chennai and Mumbai had similar observation. The peripheral arthritis was one of the important aspects of Indian population presenting as spondyloarthritis. But the keen observation raised by the observers were delayed diagnosis, poor referrals, issues of primary care providers because they never knew what is the disease, they would never refer. So delayed diagnosis was inbuilt, and the poor referral system that we have still requires, some mechanism, some redressal, and that's our problem. The financial implications, yes, and it has been there at that time, and it's still pertinent today. There are logistic issues which Dr. Vinod Ravindran actually highlighted in a very simple word. If I am at Noida, just next to Delhi, the patient population I see comes from the remotest part of Uttarakhand. It takes 18 hours. So you can understand the problems of logistics. How would the patients come and flow to you? So we do not know. And alternative therapies is something patients look forward because they cannot afford biologicals. These are the stark reality of present life. There were also certain studies that were done in the other areas, say Northeast India, where they did clinical presentation and subtypes of spondyloarthritis. The basic research work is there in hand. There was something that we loved, sulfasalazine in ankylosing spondylitis. And there was a small study that was done at PGI Chandigarh, where the lead author, Sifali Khanna Varun actually highlighted that in certain subsets of patients, young patients coming within, say, 4 years, this drug is effective, at least in the peripheral arthritis. So there was a place of sulfasalazine even in management of spondyloarthritis. However, it was minuscule in terms of the percentage gain that you will gain in an established or a disease which is very aggressive. There was another question that was very pertinent, biologicals and TB risk in India. And there were good work done and chapters contributed to address the unmet need of how to prevent TB reactivation in a patient population who were exposed to biologicals. One done by Professor Malviya, the other under Dr. Professor Handa. The next question was, how are we moving in and what is the other ideas from the other centers? Praveen Patil at Pune, he did his exemplary work with Bharati Vidyapeeth and Pune College of Pharmacy at just 100 patient data, where he addressed and identified a median delay of diagnosis of 2 years and disease duration of 5 years. So from being 8.7, it has come down to 5 years, delay of around 2 years. So it's something which is changing. That change is being reflected. The worst is that patient, before they visit their rheumatologist, they would have visited 3 specialists. So the awareness of a specialized department of rheumatology or the rheumatologist being the care provider is still unmet need. 68 patients were diagnosed incorrect. So there is some problem in our diagnosis. So they would have been diagnosed as rheumatoid, they would have been diagnosed as something else. And 8% of the patients out of 100 were jobless. They were unemployed. And this is something which is what we do not want. 20% of the patients had the work issues, work productivity and presentism as a problem. And day-to-day activity was affected in 40% of the patients. But the worst that was reflected should be highlighted as 58% of your patients actually had a trust deficit with the treating rheumatologist. They felt the doctors do not inform them well. So this is something work in progress that we need to inform our patients and take their consideration and their emotional question, viewpoint that they should be addressed and their questions to be addressed correctly. One thing that was highlighted in the study was if you have a very high disease activity, the chances of you able to work or able to work on a day-to-day basis comes down. So unable to work, which was statistically important, was applicable when you have a very high disease activity. So if you have a high disease activity, you are unemployed or your chances of becoming unemployed goes up. So this is something that we need to change the curve. So if we can make a person's BASDAI come down, can we change the curve and make this unemployed or jobless person come back into the job, or the person who has to take multiple abstaining from the job or the work productivity. So you can have unemployment or underemployment that needs also to be addressed. So if you can change the curve from high disease activity to low disease activity. The other aspect of this study was HLA-B27. So if you see HLA-B27 as per textbook, 95%, but in our population, in this group, they identified HLA-B27 to be positive around 79% in male and 64% in female. So this is something that we now are able to accept that the HLA-B27 may not be there in the region of 90. You can have a bit less HLA-B27, and that is also there in world literature. The special interest group of IRA for ankylosing spondylitis or axial spondyloarthritis, led by Professor Ashok Kumar and Dr. Ramnath Mishra, and able led by the other co-workers, published a data where they identified among the rheumatologists the gaps that are there in meeting the patient's unmet needs. So one of the gap was they identified was a good number of rheumatologists, around 50%, were not using the correct terminology of saying Axial SpA. The BASDAI was the commonest tool that they used to monitor. And one thing that was highlighted by multiple responders, all rheumatologists, was they are able to get the MRI. So to get an MRI is very easy in this country. So same-day MRI is available in around 43%. And COX-2 inhibitors are the favored drug among the NSAIDs. And sulfasalazine is the favored drug, especially when it is peripheral arthritis. And they identified financial constraint as the biggest determining point of care. So if the person stops a biological, it has to do with multiple times the financial reason. So it is not the side effect, but it is a financial constraint. We do not have multidisciplinary team to take in account of all the patient need. That is also highlighted. We don't have the trained nurses, the physiotherapists working in tandem, and patient support group is very, very poor. So the identified challenges are financial constraint. They identified that early MRI is possible in certain subset, but not all. So there is an inability for large group of patients who do not have resource to actually get an MRI. So we have a problem of haves and have-nots in health care. Lack of awareness of patients and other health professionals about the terminology Axial SpA is very, very big problem. The delayed referrals still exist and misconception about NSAID. Despite that a good amount of literature is available, people still consider it as a big painkiller, both by the patients and the primary care doctors, and not something like a disease-modifying drug. And low-cost effective therapies, formation of patient support group, having a multidisciplinary team, and training general practitioners, physicians, and orthopedic about the Axial SpA and its concept, and putting up a lot of data into the Indian Spondyloarthritis Registry was a valid suggestion put by this group. So moving from our problem, we also have identified multiple problems, and we are getting certain of those problems addressed at somewhere else, but not in India. One was the unmet needs in the French cohort as well as the Germans, but the Germans are well advanced, so they think something differently. One was they addressed the question, will AI aid in diagnosis of spondyloarthritis? This was a German experience, and they did it very clearly. They identified young people who were Googling whether they are having backache, what are the issues of the backache, what is the type of a backache. So they Googled certain words, and using AI, the German registry identified which are the areas in the country in Germany where people are having this problem. And they try to address this problem by getting in touch with them. So if I use AI, and even if I do not know whether my backache is to be addressed by a rheumatologist, if I'm putting up the data, backache, how to address it, who is the best person, there should be something that should prop up. Have you seen a rheumatologist? Something like that. So this is the German experience, and India is a leading in terms of software, in terms of IT. So we can expect. But something that people were also looking was life expectancy. So our patients also look for the word life expectancy. They have this inherent doubt. What about their life expectancy? They also look about the end stage, the course of the disease, the degree of disability, the cure if possible, the early stage or the late stage, early retirement. Can you halt spondyloarthritis? These valid human questions in Germany are the same questions which our patients also address at a point of time. And the desire of having children and the children getting affected, the work disability, these are all unmet needs are also applicable to our country. So, moving ahead, how can we address these questions? Do we have the large-scale genetic analysis, the microbiota analysis, the database of big data? Can we have the construct of diagnostic algorithms, the therapeutic strategies based on the prognostic factors? These are something that will be addressed only when we have those important data available, and that is a work in progress. This is how future axial spondyloarthritis would be addressed, these unmet needs. So we have a lot of biomarkers, but some of the biomarkers are easy to access, say ESR or CRP. So we look into the sensitivity and specificity, we debate. We also look onto the objectivity. We also look into the combination of biomarkers which can give a better yield, whether a peripheral arthritis of spondyloarthritis group or the axial disease, or when they have the extraarticular manifestations, which biomarkers to be used. So there are a lot of candidate biomarkers. Some of them can be used in the clinical domain in near future, and these domains are important. Probably Dr. Nigil may address. And there are a lot of ideas that we have in our mind. There are challenges we face worldwide. And one of the idea was treat to target. Is it a valid concept? So do we have the validation to say that this is a correct concept? And there are very prospective studies to deal with this. The difficult to treat disease in spondyloarthritis, again, an unmet need for anyone in India. What are the combination of targeted therapies? We have started looking, can we combine, in which sequence? So that is, again, we do not have the data, maybe we get from outside. Paucity of head-to-head studies outside, say TNF-A versus TNF-B. Can we use targeted DMARDs as a first-line agent, which is what we do in India? So do we have similar ideas coming from the Western world? Can we address that issue? Can we use MRIs or CRP, normal individuals, negative MRI, normal CRP, the first-line agent or JAK? The first-line agent here means TNF or IL-17 inhibitors. How to navigate a partial response. Gender-associated issues have not been highlighted much in Indian studies, so diagnosis and management in females remains a question to be addressed. Since we can have number of MRI machines, we have also learned the risk of overdiagnosis. How to read this MRI has become a part of our job. We need to understand with the age, the BMI of an individual, the morphology, the job that they do. And the next question is, will the new changes in the MRI make us better so that we err less and make less overdiagnosis at least? So can Vibe MRI give me a better answer? Can I use a low dose CT and make a better answer? So these are the unanswered questions. The persistence of targeted therapy is unanswered in Indian context. How long can we use a JAK inhibitors? They're quite cheap to our population. How long? At what age group we can say that we can continue for a few years? We do not have the answer. The persistence with other drugs of targeted nature like the IL-17, etc. is again unmet need. The state of affairs in India is marred by few things: poor referral practices and a clinical nihilism that we need to change. Our ideas should be on the positive aspect. From being undiagnosed to underdiagnosed to misdiagnosis, we need to bridge the gap. And at the end of the tunnel, if you want to score perfect 10, even if we have a few drugs, and there are things which are changing in the spondyloarthritis landscape, there are exciting molecules in development. So hold your breath, you will have a perfect landing. There would be a biomarkers which will change the way we treat our patients. It is a still long way to go, but it's the words to wait, words to understand, and words to go. Thank you for your patience. Now I hand it back to Professor.
Thank you, Dr. Bimlesh Pandey. I think that was a fantastic overview of what all we face when we are trying to manage our patients with spondyloarthritis better. And on that background, I think it's perfectly set now for Nigil to update us on what is new in this area. Over to you, Nigil. Thank you.
Thank you very much. Very kind of you to invite me to one of the very first two IRA eConnect programs. A fantastic program. I'm really happy to be here. It's a privilege to be here indeed. And Dr. Bimlesh, you took me to those old days of working in Lucknow and the stark reality of how patients travel long distances and come and try and seek help from specialists in cities. So thank you for setting the stage as well, Chandra Bose. Thank you for the introduction. Hopefully, I'm sure IRA is having a great year under your leadership. And Vinod, thank you for setting the stage and opening the program. IRA, thank you for invitation, and Abbott also for inviting me and giving me this opportunity. So the goal today is really to explore therapeutic targets, and what I have done is try to cover more recent concepts on axial spondyloarthritis, and right at the end, if we have time, and Vinod, you can just stop me if we are shooting over time. If we have time, we will cover some of the new molecules and work that is currently going on in our center. Okay, so these are my disclosures. So these are the things which I hope to cover today: the current treatment options, the concept of window of opportunity, of tapering of medications, pathogenesis, and the current insights that we have, now some novel therapeutic targets, and finally future directions. So when we talk about treatment of axial SpA, it's not just about controlling disease activity. When disease activity, PASTA is important, but for patients, there are a lot more domains that are very important for them. So pain itself, fatigue, mobility, quality of life, ability to work, these are also important for them, so we should never forget those outcomes. Long term, as a physician, you do realize that you do know what is coming, and you realize that the actions you take today could make a difference. Spinal fusion, nowadays patients are almost all aware, with Google being available. Once you give a diagnosis of ankylosing spondylitis or AxSpA, they will go and look at it, and they've all seen pictures of patients having spinal fusion, so they're aware of the risk. What is probably not that commonly known is the long-term cardiovascular risk. So our treatment objective should also make sure that the risk of cardiovascular events long-term is minimized. So what are the treatment options available? And I made this slide based on the AxSpA guidelines that are available. The most recent ACR Spartan guidelines are just in the process. It'll come out likely within a year and a half. But so I've just modified the recommendations based on the most recently approved medications as well. So non-pharmacological treatment and physiotherapy, home exercise, group exercises, all very good and beneficial. And pharmacological side, as we all know, anti-inflammatories are the first line. DMARDs have been used, and Dr. Bimlesh showed a study on sulfasalazine, so it is being used widely. Unfortunately, for core axial symptoms, disease-modifying drugs have not been proven to be effective. Once patients fail anti-inflammatories, I think of the options as 4. Some may think of it as 3 options that are available, and these are TNF inhibitors, IL-17A inhibition, IL-17A and F inhibition, and JAK inhibition. So these are the 4 modalities available for treatment of axial SpA. Many of these other medications that we have seen being used in primarily rheumatoid arthritis and also in conditions like CNO and psoriasis and IBD. Unfortunately, again, for core axial symptoms, none of these are effective. As I mentioned, sulfasalazine and methotrexate all can be used in the 30 to 40% of individuals who have peripheral arthritis or enthesitis and other peripheral manifestations. We tend to use them if the uveitis is not perfectly controlled with the biologics. We can also occasionally add them on top of the biologics if we feel that the patient is developing a lot of immune tolerance to multiple biologics, so you don't want to take a risk of the next one also failing. Some people tend to add it, but it's not a very common practice in AxSpA. Okay, so let's look at maybe just the 2 most recent medications that were introduced in the pipeline. So this is the Select Access 1 study. And here, patients who were included, you can see the inclusion criteria there. Active AS patients who met the modified New York criteria, BAS time more than 4. And around 187 patients were randomized. The primary endpoint of the study was ASAS-40 at 14 weeks. And there was an open label extension also. So the whole idea is for patients who are taking upadacitinib, which is the most recent JAK inhibitor, the dose is 15 milligrams daily compared to placebo. What is the ASAS-40 response at 14 weeks? And you can clearly see there is a significant improvement in ASAS-40 responses when you're on upadacitinib compared to placebo. And once the patients cross over, they catch up over a period of time. You can see the rapidity of response with this JAK inhibitor. So you can clearly see it's a very effective medication. Of course, with JAK inhibitors, there is a question of safety over time, and this is an integrated analysis. We used this slide during the global launch of upadacitinib, so I've just taken it off that slide deck. And you can see the PSA data here, AS safety data here, and integrated RA safety data here. Fortunately, serious side effects and death and major adverse cardiovascular events and VTE, it doesn't stand out as a major issue with upadacitinib. Okay, that was a pleasant, but it was great to see this study from Rudra. I was looking at TOFA because I was doing UPA. I thought I would do TOFA as well. So this was a nice comparative effectiveness study of TOFA and adalimumab in AxSpA. 266 patients included. And the bottom line is TOFA showed comparable effectiveness with adalimumab in patients with AxSpA at 6 months with a favorable ICER or incremental cost effectiveness ratio. So this is the most recent drug that was approved in Canada for Axial SpA. It is still not approved in the US, and I am not sure if it's available in India yet. Maybe you can let me know at the end. So there were 2 studies, B-Mobile 1 and B-Mobile 2. The B-Mobile 1 is in non-radiographic AxSpA. B-Mobile 2 is in radiographic AxSpA. 250 to 300 patients in each of those studies. Same design for both radiographic and non-radiographic. Primary endpoint is at 16 weeks and it's ASAS-40, so placebo-controlled first phase. And afterwards, everybody moves over into the active drug. The dose of the drug is 160 milligrams once a month or once every 4 weeks. Okay, here we look at the non-radiographic AxSpA data. You can see week 16 data, ASAS-40 is close to 50%, and by week 52, 60% of individuals get the ASAS-40 responses. Okay, this is for radiographic AxSpA, similar response. And you can see that radiographic and non-radiographic AxSpA patients respond similarly for bimekizumab, which is the IL-17A and F inhibition, similar results for 52 weeks as well. So this gets very interesting. As you look deeper into the data with combined IL-17A and F inhibition, there are some interesting points, and one of that is the efficacy in TNF inhibitor naive and inadequate responders. So if we look at week 16 data, see 46% ASAS40 response, 45% ASAS40 response. So it doesn't matter whether patients have already failed a TNF inhibitor, they seem to get similar efficacy with the IL-17A and F inhibition. And generally, we expect a slight drop of 5 to 10 points when we go to a biologic from a biologic naive to a biologic experienced population. Safety. So this is important. So I was very interested in seeing how patients really respond to IL-17A and F inhibition, having understood the biology of IL-17F and its importance in different target tissues. There are no major drug-related treatment adverse events, no major serious adverse events were known. But one thing was very clear, the candidiasis volume, you can see that in the MeMobile one at 52 weeks, 15% had fungal infections, the vast majority being oral candidiasis. So this is slightly higher than what you would expect with the IL-17A inhibition alone. Fortunately, no major systemic fungal infections. And there is a lot of experience in psoriasis patients already over the last 2-3 years. This was also very interesting to see. In general, we don't think about IL-17 inhibition when patients have uveitis. So if you look at this sub-analysis, and there are more studies that are ongoing currently on the uveitis side of things, you can see compared to placebo-treated patients, lower risk of uveitis in bimekizumab-treated patients. The risk reduction is even more clear when we look at patients who already have a history of uveitis. And as you know, you have a history of uveitis, the likelihood of another flare is higher. And you can see the flare rate in the placebo group compared to bimekizumab group. So very interesting. We have to wait and see if this is validated in other studies as well. Okay, so those were all that I wanted to mention from the actual treatment perspective and what is new in treatment. Now let's go to the concept of window of opportunity. Okay, so early diagnosis of Axial SpA means early initiation of treatment, and early initiation of treatment means higher chance of response, higher chance of drug-free remission, and I feel the higher chance of slowing progression of disease. So these are the pivotal studies of TNF inhibitors in Axial SpA, and as you can see at 6 months, so it's at 24 weeks, the ASAS40 responses are less than 50% in all of these studies, so almost similar. And now let's go to IL-17 inhibition. This is just an example from secukinumab, anti-TNF naive, and you can see anti-TNF inadequate responders. The ASAS40 response at week 16, around 43%. Okay, and here is a JAK inhibition. So upadacitinib study, for example, you can see the ASAS40 response also similar at around 45-50% or so. So what you see is that whether it is JAK inhibition or IL-17 inhibition or TNF inhibition, you only can get to around 50% of ASAS40 responses within that 4 to 6 month period. And the major characteristic I think in these studies is the fact that patients who were included in the study already had 10 to 15 years of disease. That is one of the major drawbacks of treating late. Let's take an example of this study. Now here you have patients who were included at less than 3 years of disease duration. And I will ask you to just look at this specific bar here, the partial remission bar. Within 16 weeks itself, over 50% of individuals have gone into partial remission. ASAS40 response is about 60% within first 4 months itself. So clearly there is partial remission is not so easy to achieve this early. And I believe that the difference here is that patients have been treated early, and also very important to know that they are B27. All patients are B27 positive or an MRI positive, which also further increases the chance of response. So likely there is a window of opportunity in treatment response. Now let's look at non-radiographic axial SpA. This was a post-hoc stratified analysis of certolizumab PEGOL study, and you can see here out of the 300 patients, those who were on certolizumab and placebo can be further stratified into those who had less than 5 years of symptoms and more than 5 years of symptoms. And straight away going to the data, you can see the ASTAS major response was achieved in this group, and that is the group who were on certolizumab but also had lower disease duration, less than 5 years disease duration, as opposed to later disease like after 5 years of disease duration, which is a lower response that you can get. So clearly for both AS and non-radiographic axial SpA, if you treat early, there is a higher chance of response. Now coming to disease modification, and this was one of our studies that we did way back in 2012, use of TNF inhibitors was associated with around 50% decreased risk of progression. But when you again do a sub-analysis and stratify them based on what was the disease duration, you clearly see that if you start the drug early, the rate of progression is much lower. And another way to look at it is you look at the cumulative probability plot and see that those out of all patients who started the drug late, 60% progressed, while those who started early, only 20% progressed, which was quite a striking difference here. Again, showing the window of opportunity. So the window of opportunity concept is stopping there, but for completion of disease modification, I'll also show you some data on IL-17 inhibitors. And this is the most recently published study of secukinumab versus adalimumab biosimilar in radiographic progression over a 2-year period. And you will see here that these are bio-naive patients who have active disease with increased high sensitivity CRP level or presence of at least one syndesmophile. So they are at higher risk of progression compared to our usual cohorts that we see. So the idea was that if you take these patients with higher risk, maybe 2 years would be enough to show a difference. There was a low dose or commonly used dose of secukinumab, higher dose of double dose of secukinumab and adalimumab biosimilar. And you'll see here 860 patients randomized and around 250 patients in each of the 3 arms completed the study. Well, the bottom line, no difference. Okay, so both doses of secukinumab were not different from adalimumab, whether they were CRP positive and negative, syndesmophile plus minus, or both positive. So clearly no difference. If you look at the mean change in MSAS also, there was no difference. So essentially, the use of IL-17 inhibitors are at least as good as TNF inhibitors in reducing rate of progression, or both are equally bad. You can look at it that way, because there is no control arm with no treatment here to really say. Similarly, if you look at JAK inhibitors, this is upadacitinib data. You can look at the SPARC scores. The SPARC MRI spine score significantly improves, sacroiliac joint score significantly improves, and showing that because inflammation is significantly improving, potentially the bone formation should also improve. There are MRI studies also looking at SI joint structural changes, which have also improved with JAK inhibition. Similarly, you can see the same with tofacitinib as well. Compared to placebo, look at the patients achieving minimal improvement for SIJ scores, and pooled 5 mg BID and 10 mg BID dose significantly better. Similarly, if you look at the spine score as well on tofacitinib, significantly better. So again, similar concept. If they're improving their inflammation on the MRI, hopefully that will translate into disease modification as well. The final part on disease modification that I have for you is the role of NSAIDs. And we've all seen many past studies looking at NSAIDs, celecoxib study, the Wander study showing maybe a potential benefit, but then subsequently the diclofenac study showing no benefit. Now the question here is there a benefit of adding NSAIDs on top of a biologic? Normally our practice is that if you are on a biologic and the patients are doing well, generally we ask them to stop the NSAID because unnecessarily they're being exposed to the NSAID toxicity. So here a study under Dennis Podobny's team was looking at the benefit of adding NSAID celecoxib to golimumab. And you can see here the number of patients, 128 patients enrolled and 109 randomized. Around 50 patients completed the study in the NSAID plus TNF inhibitor group versus TNF inhibitor alone group. And here are the results. There seems to be a decrease in the change in MSAS with the celecoxib on board or the development of new syndesmophytes, but this was not statistically significant. So the conclusion is that there is no difference whether you add NSAIDs or not. And again, keep in mind, 2 years is such a short period to study MSAS progression. So cumulative probability, no difference in SMAL progression between the groups. Okay, now moving on to the biologic discontinuation concept. Okay, so we'll start with maybe the first study that explored this. This is the ABILITY-3 study where adalimumab was given to patients. After the first 28 weeks, if patients were in sustained remission, .673 patients were enrolled, of which 305 were in sustained remission and further randomized. And the final analysis is looking at the proportion of patients who did not experience a flare, which is defined as an ASTAS more than 2.1. Okay.
Sorry, Nigil. I think you stopped sharing your slides. Something happened?
No.
No,
Looks like it kicked me out.
It's not visible. Yes. You are there online. Just you have to share it again. Yeah.
You have to reshare, sir.
Okay.
Reshare, yeah. Please.
Is it good?
You are there. Yeah.
Okay.
Go full screen.
Okay. Did you see this slide before?
Yeah. No, you are at it.
Did you see the slide before?
You are at that particular slide. Carry on.
Good.
Yeah. Carry on. Thank you.
Very nice. Yeah. So the ABILITY-3 study, so I was explaining, 673 were enrolled. After the open label phase of 28 weeks, 305 patients achieved sustained remission. Okay, so that's a good number of patients. Now the question is, if you now withdraw at sustained remission, what are the proportion of patients who do not experience a flare at week 68? Okay, so over a 40-week observational period. Well, the bottom line is a significant number of patients will flare, right? Significant, especially going to placebo. Even if you continue on adalimumab, you expect a flare rate, small flare rate, but way more patients, if you stop the drug, will flare. And this is roughly the percentage of patients without a flare. So if you continue, only 30% flare, but nearly 50% would flare if the drug is stopped. Okay. What about can we retreat? And you see that it's very difficult to achieve sustained remission. And once they flare, if you try to recapture again within the next 12 weeks, only around 55 or 60% of patients could be recaptured back. So it's perhaps not a good idea to just stop the medications. Okay. So now let's look at the C-optimized study. If drug withdrawal is not a great idea, how about drug tapering? So this was the first study where patients were randomized into a lower dose and a placebo in addition to continuing the full dose. So you'll see here the regular dose of certolizumab pegol is 400 milligrams a month, which is 200 milligrams every 2 weeks in this particular study. And if at 48 weeks, so this is another difference here. There was a longer period for which patients were on drugs, so perhaps they would have gone into deeper and more sustained remission. So this is a little bit more reflective of the regular practice. In fact, in our practice, we start tapering only after much later if they are in sustained remission for almost a year, which would mean almost 2 to 3 years into treatment. Okay, so if they were in sustained remission, 313 patients were further randomized into continuing the same dose of 200 milligram every 2 weeks, or half the dose, 200 milligram every 4 weeks, or going completely to placebo without any active drug. And here is what happened. Continuing same dose and half the dose, not much different. You stop the drug, almost everybody flares, right? So that's not a great idea. Again, showing that stopping is not good, but tapering is very good. Normally, we don't go to half the dose immediately. Even if you go to half the dose, it looks like there is not much of a difference. Normally, our practice is to start increasing the gap. So if it's every 2 weeks, you go to every 3 weeks, then to every 4 weeks. So it's a much slower, gradual taper that we are used to in clinics. Now, this, again, another interesting study from our Padmanabha Shenoy, tapering tofacitinib for AxSpA in remission. And again, nice to see these studies coming out of India. You can see at a median of 7.3 months of tofa tapering, 85% were on a much lower dose of between 25 and 75% of the actual dose. So it's possible to taper these patients on a JAK inhibitor as well. And if you read through the text, you also see that if they tended to flare, going back to the previous higher dose would easily recapture those patients. And the predictors linked with flare, if they have radiographic disease or they already use a prior DMARD, and if they had a higher disease activity at baseline, maybe you should be careful when you taper or make it very, very gradual. So that's another study. Okay. Now, let's go on to the future directions. And here I will probably go a little bit slower because there's a lot of new concepts on immunology in some of the more recent work that I've been doing. I believe we have around 15 minutes more, so I'll try to use that time for this. Vinod, please stop me anytime if we are running over, please. Okay, I can just wind up within that time period. So B27 is been associated with AS for over 51 years now. Okay, so even today, if you ask me how does B27 actually lead to disease, I won't be able to give you a straight, simple answer because we really don't know. What we do know is that B27 is an MHC class 1 molecule, so it's an important antigen-presenting molecule. HIV patients who are HLA-B27 positive are less likely to develop into AIDS because the HIV antigens can be nicely presented by HLA-B27, so you get a good immune response. Similarly, hepatitis C virus patients are less likely to progress into cirrhosis because of the same reason. However, Northern European cohort patients, 90% are B27 positive. If you come to Toronto in our cohort, around 80% or slightly lower are B27 positive. So there is very high prevalence of B27 among AS patients compared to around 5 to 7% in the general population. So clearly there is something very important that B27 is doing. Now, if you look at the B27 and associated molecules in that pathway that are involved, okay, we have the B27, we have a target protein. A lot of people have tried to look for this target protein. Some say Klebsiella, some say influenza, and many other similar proteins or target proteins have been explored, but none have been really confirmed. Then there is the immunoproteasome that clips all the target proteins after ubiquitination into smaller peptides, and the smaller peptides enter the endoplasmic reticulum through the TAP molecules. Okay, the TAP molecules. So the transporter associated with antigen presentation. And once inside, these peptides have to be trimmed by ERAP1 and ERAP2. These perfectly trimmed molecules then sit on the B27 and they go to the surface. Okay, if they don't sit properly, then there is a possibility of unfolded protein response and inflammation happening there. There is a autophagy activation that can come in to reduce the risk of inflammation and cell death, trying to protect the cell. Normally the ER exit happens through the formation of COP2 vesicles, and the B27 peptide complex can go from the ER into the COP2 vesicle and to the surface where a T cell will come in and respond to this. So you can see that I've numbered several steps in this process, and things can go wrong in any of these processes. In fact, the reason why only 2 to 3% of B27 positive individuals develop disease is because you need multiple hits along this pathway with multiple molecules being affected before AS really develops. So inherently there is a protective mechanism within the body to avoid developing a chronic inflammatory disease, because there are many other pathways that need to go wrong for the disease to actually develop. And all of these marked genes have been associated with AS. Immunoproteasome LMP2 polymorphisms have been associated with AS. ERAP1 and ERAP2 are strongly associated with AS. Sec16A, we have published a study that looked at the formation of COP2 vesicles and in a family of axial SpA, multiplex axial SpA individuals, and 9 individuals who had a mutation in Sec16A that leads to COP2 formation and were B27. All 9 developed axial SpA, 100% penetrant. So you can see some of these players can be very, very strong in the pathogenesis of axial SpA. Okay, a beautiful diagram from Bob Colbert's group. Once the unfolded protein response is triggered, one of the most important cytokines to be released is interleukin-23. Interleukin-23 further triggers a Th17 cell that has an IL-23 receptor on the surface. This is yet another gene where polymorphisms are linked to AS. So you can see that pathway doesn't stop with just B27. Even downstream effects of that pathway can be genetically affected. That further releases IL-17, and then you have further release of TNF-alpha from there. So I'll move on to some of the new studies and new targets that we are looking at. So we talked about target proteins being ubiquitinated and going into the proteasome for further degradation. So you can see here the ubiquitin proteasome pathway. So ubiquitination happens with ubiquitin conjugating enzymes, ubiquitin protein ligase, E1, E2, E3 sequentially acts on the substrate. And after multiple cycles, you get a ubiquitin chain on the substrate that targets it to the proteasome, and finally you get the peptides that goes into the MHC class 1 molecule. Now, to prevent overactivation of this pathway, we also have the deubiquitinases, and Trabid is an interesting deubiquitinase that removes the ubiquitins from the substrate. The reason why we got interested in this is primarily because of 2 reasons. One, of course, the ubiquitin protein pathway. We've been working on this antigen processing pathway, so we got interested. But the most important reason is because there was a publication that suggests that Trabid could drive IL-23 production, and that suddenly, perked our ears, and we were thinking, okay, IL-23 and antigen processing presentation pathway, maybe it's an interesting molecule to study. So we started looking at Trabid. So the first thing that we did was to look at what are the protein interactome. What are the proteins that are interacting with Trabid? And of course, you see the class 1 MHC, antigen processing and presentation pathway with TCR signaling, which is expected because that is the antigen processing and presentation pathway is linked to ubiquitination. But interestingly, now let's look at the pathways where you have the highest values here. TNF induced NF-kappa B signaling, TNF receptor 1 signaling, TNF signaling, MAP kinase activation, IRAK2, so NF-kappa B. So you see a lot of inflammation linked pathways that can be directly affected or indirectly by Trabid. Now let's look at this. SMAD, beta-catenin. So a few of the bone-related stuff, signaling by Wnt, are also related to Trabid. So now you can see that pattern. Inflammation, bone formation, both could be directly linked to Trabid, and it may be independent of the deubiquitination function by which it could play a role in AS. So we are still at the exploratory phase. So we go ahead and take a look at Trabid expression in the tissues that naturally we have to see if our story sticks, right? So let's see what we found. So if you look at AS patients' synovium, bone marrow, and gut, compared to healthy controls, significant overexpression of Trabid. So the target tissues where there is inflammation, there's a lot of Trabid there. Okay. Now we go to the mouse model. After you give Curdlan to SKG mice, they develop disease, significant overexpression of Trabid in the spine and also in the peripheral joints. So you can see the Trabid is clearly different in diseased mouse and in patients with AS in the target tissues. So things get even more interesting. Now, I don't want to show you all the data with the study because we have done in vitro studies, we have done ex vivo studies. Essentially, this is the main story here. If Trabid is so important, would inhibition of Trabid be helpful in treating AS? And here we use a preclinical model, the SKG mouse model, and this is an inhibitor. The dose is every 5 days. You inject the inhibitor after injecting curdlan. If you don't inject curdlan, there is no disease in the mouse. With curdlan, there is a lot of disease in the mouse, the SpA features of arthritis, eye inflammation, and skin inflammation. With increasing doses of TRAbid inhibitor, you can see significant improvement in these clinical features, again showing and validating our thought that TRAbid is a good therapeutic target in AxSpA. Okay, so that's one of the molecules I wanted to talk about. The second one, of course, is MIF. I cannot go without talking about MIF. So we have really worked on this for over the last nearly, I would say, getting to 10 years now. We've been working on this, and this was one of the earlier studies, and we started off very small initially, just looking at serum levels of MIF, and got that published in ANR. And after that, we went on to do mechanistic studies in the animal model and looked at MIF in the SKG mouse model, got that in STM. And finally, the most recent one is looking deeper into how MIF actually leads to inflammation. And we found the MIF-IF interaction, mutual interaction that actually drives neutrophils to produce type 3 immunity and chondrogenesis in the preclinical model of mice. So there's a lot of data in here, but I will just summarize it in one slide. So initially, AS compared to healthy controls, MIF looks like a good biomarker. Is it really a therapeutic target? We don't know yet. If you look at progression, progressors are higher than non-progressors, but it's a widespread. So we did a multivariable regression analysis, and even after correcting for all the baseline variables, MIF was an independent predictor of progression. Then we went on to show that MIF can actually trigger inflammation. It can trigger bone formation as well. Then we went on to look at tissues, and this is the AS spine compared to osteoarthritis, significantly increased MIF expression in the spine of patients with ankylosing spondylitis. Okay. Then in the mouse model, and this is how the mouse model behaves with arthritis, tail spine involvement, psoriasis-like changes, all there, where we showed that there is activation of type 3 immunity. MIF overexpression could be seen in these mice. Instead of curdlan, if you just overexpress MIF, the mice develop disease. And if you inhibit MIF or knock out MIF, the mice significantly improve, showing the key role of MIF in this inflammation. And finally, we also showed that neutrophils are the most important cells that produce MIF and that can infiltrate tissues, leading to significant spondyloarthritis features. And there is now more and more interest for looking at neutrophils in spondyloarthritis patients. So that field is now just evolving. Okay, so the last part, and hopefully in the next 5-6 minutes, I will be able to cover this as well. So we talked about the antigen processing presentation pathway. Now imagine if you are exposed to an arthritogenic peptide, and for the sake of argument, let's say it is a viral infection, and let's take flu as an example. So you genetically, you're vulnerable with B27 and maybe an ERAP mutation and maybe an IL-23 receptor mutation. You have 3 or 4 key, key polymorphisms that drive you to a pro-inflammatory state and pro-arthritic phase. And then you get this infection, and then everything is triggered. So when the body responds to a particular antigen, there is clonal expansion of these cells. And here you're talking about CD8 T cells responding to B27 presented antigen. So you would expect a CD8 T cell clonal expansion. So when you look at the distribution of T cells in the peripheral blood, if there's suddenly one clone pump, just strikingly is different from those without exposure to the antigen, you know that these T cells are the ones that are responding, right? So that's the idea behind this study that Paul Bonas and his group actually did. It took patients with AS, patients with acute anterior uveitis, looked at 2 tissues in both groups. One, of course, peripheral blood, and same peripheral blood for uveitis patients. Target tissue in AS was synovial fluid. Target tissue in uveitis patients was ocular fluid. And then the idea is you isolate the PBMCs or the target tissue cells, ocular fluid cells and synovial fluid cells, and you sort them and try to look for V beta 9 positive T cells, and you try and sequence the actual TCR. And why V beta 9? Because many people have previously shown that it is the T cells, CD8 T cells, that have the beta chain V9 that is expanded. And in this study also it was expanded. So they took out the V beta 9 positive T cells, CD8 T cells. They also looked at sequencing of alpha and beta chain. This was the first time the alpha chain also was being sequenced, and they showed an expansion of these T cells. They went backwards and tried to predict, and also use experimental techniques to identify which antigen is actually driving these T cells. Unfortunately, they couldn't narrow it down to one or two, but they did have a small set of antigens that are probably driving these cells. Now, here is the interesting story here. If you look at the synovial fluid compared to blood, there is significant increase in the clonal expansion in the target tissue. Similarly, in the eyes also, there is significant increase in expansion of the target tissue. So you have these interesting V beta 9 expressing T cells that are responding to some antigen and causing inflammation in your system. So if that is the case, could we actually follow the same principle that we do in lupus and rheumatoid arthritis, where you use rituximab to take care of the B cells and take it out of the system? Can you actually use a monoclonal antibody, or even better, maybe more recently, CAR T cells, to take out the TRVB9 positive T cells for helping patients with ankylosing spondylitis? So that's the whole idea. And this was and the main reason behind this is that V beta 9 expressing T cells are only 4% of total human T cells. So essentially, you're taking out the pathogenic T cells, but 96% of your T cells are available. It is unlike what you do with B cell therapy, where you remove the entire B cell population from your blood. Here you're taking out only 4% of your T cells. 96% is available for your immune response. So that's the beauty. If this is effective, take out the TVR B beta 9 T cells. So the authors actually showed that if you use a monoclonal antibody in different doses, you can achieve depletion of the CD8 T cell V beta 9 population. Now let's come to the story of this patient. So this was a single patient story. Patient was first symptoms in 83, diagnosed in 86, went on to TNF inhibitor therapy in 2004, had a stem cell transplant because things were not improving in 2009. By 2019, started using the TRV beta 9 antibodies. This is the dosing, once every 4 months, increasing dose of 60 milligrams all the way up to even 500 milligrams. Now, here is what we were waiting for. The results, you can see the ASTAS significantly improving and staying low there. Similarly, if you look at spinal mobility improving, you can see the all the other disease activity measures significantly improving, and the physical function improving on treatment. So, interesting idea, interesting concept, very early report. They actually went on to do a phase 2 study of this molecule, the BCD. It's called the BCD 180, and it included this. You can see the number of patients here: 103 patients on the 5 milligram per kilogram, 107 on 7 milligram per kilogram, and the placebo around 50 patients. There is a difference from placebo, but if you're thinking of this as the major culprit in disease, I would have expected a lot more response, or perhaps they were too late in starting treatment. Maybe the response would be different if you start much earlier in the phase of treatment. So finally, the paradigm of axial SpA management has changed. 4 different mechanisms of action for treating axial SpA now. There's an emphasis on early diagnosis. There's a window of opportunity in treatment of both AS and non-radiographic axial SpA. Very good data on disease modification now. There are some predictors of response to biologics that have been proven multiple times, and these could help guide you in selecting patients for treatment. Even better would be in the future if we have a personalized medicine with a nice algorithm with which you can select. There's a lot of work going into that. Dose reduction is possible, but stopping biologics is not a good strategy. And many, many novel therapeutic targets on the horizon, and hopefully we will see more in the toolkit soon. So this is the team behind a lot of this work, and thank you all again for this opportunity.
Thank you, Nigil.
Sorry.
Bimlesh.
This is one plug, sorry. I had just one plug for, of course, Bimlesh already talked about the Oxford textbook and the beautiful SpA chapter by Malviya sir and Ashok Kumar sir. And this is, if you want to read a lot, there is a best practice issue. And the next International Congress on SpA is happening in Belgium, Ghent. Please do come. It's a beautiful city.
So thank you, Nigil and Bimlesh, for excellent talks. So I think we have time for a few questions. So to give you a break, Nigil, I'll start off with Bimlesh. A lot of questions for Bimlesh related to TB and practicalities of treating SpA in India. And I will start off by putting you a question that suppose you have a patient who has history of inflammatory low back pain, but has normal CRP and normal MRI. What would you do? Would that, be a sort of not so common, but yet a true clinical scenario you face?
So it's a question which is valid. I will also add HLA-B27 positive and the MRI of sacroiliac joint that has been done may be negative. And there's a strong family history. I will add another word, strong family history. The CRP may not be positive in all your patients. That's why it's not the best marker. Yes, it's an excellent marker for a day-to-day practice where the patients had a CRP elevation. 30% of the patients may have a CRP which may be absolutely normal. Rule out fibromyalgia, because that's another condition that we always see. But there are other sites which can have inflammation. So if someone is very good in MRI, they can see the entheses, the interspinous ligaments may have, the facet joint may have some changes. So that's why you require very good eyes to see the inflammatory changes elsewhere other than the SI joint. This number would be quite less. It would not be the typical scenario. But if it is a strong history of inflammatory backache, you would get. And a few months back, I had a family of doctor where one of the individuals had a similar phenomena. The costochondritis was very, very predominant, and the costovertebral area was quite painful most of the time. Actually, B27, one of the brothers had already advanced disease. The MRI SI joint had probably not much change, but these areas had changed, had ultimately to go on the usual medication, NSAIDs, followed by actually IL-17 inhibitors because it was predominantly enthesitis to my mind, and it did work. So that is an odd, it is not the norm, but that can happen. And that also is a difficulty of MRI. So MRI for majority would be the SI joint changes to begin with, but we know at least from the psoriatic group that you can start in the neck in the psoriatic populations. Also look for this skin psoriasis if they have an inflammatory backache. Dr. Nigil may add something.
Thank you. And a couple of questions to Nigil. And your talk personally, I enjoyed the section where you covered the concept of window of opportunity. And this two questions are related to that. So, so the question is, the anti-TNF agents have been around for a number of years, but is there any robust data to say that they do inhibit radiographic progression? And also, if you do have to choose an agent in terms of their ability to inhibit the radiographic progression, which agent would you choose? Nigil.
Thank you. That's a tough question. Well, there is a lot of data to suggest, I would say suggest, not prove, because it's difficult to prove this. And the reason why it suggests is because you have to follow these patients over 4, 6, 8, or even longer number of years to actually see any progression, right? If you don't see progression, how do you prove that an agent actually stops progression? So because it's such a slowly progressive disease, you need to follow them over a period of time. Now, to prove something, you have to do an RCT. And how many years are you going to keep a patient on a placebo for to prove something, right? So it is not going to happen. So that kind of a study is not going to happen. So we will have to be satisfied with the next best possible avenue, which is taking cohorts that are prospectively followed over a period of time and try as best as we can to control for factors that can increase risk of progression, and see if there is a difference in those who were on a biologic or not. And that's what we have done. A lot of other teams have now done this, and the results are all concurrent. It's all the numbers that everybody lands up with is similar. So around 50% decreased risk of progression when you use a biologic. Now, there was the recent SURPASS study that looked at secukinumab and adalimumab over a 2-year period in high-risk individuals, and there was no difference between using an IL-17 inhibitor versus a TNF inhibitor. So it's very difficult to say is one better than the other. The other two drugs which we have, or types of drugs, are the JAK inhibitors and the IL-17A and F inhibitors. I don't think we have long-term actual radiographic data to really compare. A study like SURPASS with the other agents would be great to show that either equivalence or difference if there is any. So right now, I don't think we can select a drug based on its disease-modifying potential. Whichever drug is best to control inflammation in your patient is the best drug that you can do. Yeah.
Great, thank you. And then the question of or the decision of tapering or discontinuing biologics in India is almost a financial question. And even the tapering can be difficult and impacted by the financial situation. But if we do have to, is there a minimum time duration we should push our patients to have the biologics at the full dose, where we can hope that they have long and durable clinical and structural benefits? I mean, is it 3 months, 6 months, anything?
Yeah, I personally feel that at least in the initial phase, patients should get full dose biologics so that we don't keep chasing that target, right? So we should really go and control the target as soon as possible, and then then ease the grip after that. If especially in those who have a lot of inflammation, and particularly if they're already well established, it can be very challenging. You have seen the clinical trial data, even in the best of best centers with all the well characterized patients, the results are like 50-60% of ASAS-40 response. And ASAS-40 response is a good response, but still not enough when it comes to the total physical functioning and patients' overall quality of life. So it can be extremely difficult to control disease. On top of that, if you are now using lower dose of medications, the numbers will drop. But I completely understand that we have to do the best we can based on the situation. So I think the best thing that we can do is an early diagnosis as early as possible. And if you look at the INFAST trial data, when patients were diagnosed within 18 months and started treatment, even with naproxen, 35% of patients went into remission just with naproxen. And the difference is the early treatment. So I think, the emphasis really should be on educating the public, making them aware of spondyloarthritis that is amenable to treatment. It's not just another back pain. It is not just another sprain. If you have these features, do this questionnaire. And if you tick more than 4 points, go and talk to your doctor, get a referral to a rheumatologist. And then once we can start these patients early, maybe we could be better off with less, rather than wait till it's fully established and treat with less, which is I think not a good way to do things. Yeah.
And what about the non-radiographic SpA? Is there is there any clarity when do we stop biologics in them or start to taper? Well, that's a bit challenging because the definition itself is,
I know. So if we consider the non-radiographics to be the same spectrum of AxSpA as radiographic AxSpA, in my mind, I don't see a difference between the two. So if you you plan to treat, or the average duration for which you treat AS patients is 10 years, I don't think that average duration in non-radiographs will be that different. The difference, however, is going to be, the question around how accurate is your diagnosis, right? So it goes both ways. It goes both ways in the sense that the difficulty is if the patient is in a gray zone, B27 positive, MRI is iffy, not that strong, but patient is so symptomatic, you want to help the patient, you want to do something, you start a drug, a patient feels around 40% better. Do you want to stop it and go to 0%, or you continue the same and maybe it's a placebo response? So that's one part. The other side is maybe there is mechanical pain there, and the mechanical factors can actually cause inflammation. And there are studies of TNF inhibitors in intervertebral disc prolapse where patients get benefit because the local inflammation is controlled by the TNF inhibitors or any biologic. So maybe there's a situation where you have a non-radiographic AxSpA patient where, again in the gray zone, but patients respond really well. We can claim it is the drug causing it, but maybe there were some mechanical elements also to it, and to that, maybe this is a set of patients where you can start tapering and see, and if it is beneficial, perhaps stop. So I would think that maybe there is a higher chance in this small set of patients who have that mechanical element as well, but otherwise I don't see a difference between the two.
Great, thank you. And Bimlesh, this is for you. In your setting, you recommend anti-TNF agents or biological agents to patients, and they do take initially, then they're lost to follow up, and then they see you again. So then comes the question of restarting the treatment. So really, is this stopping, restarting cycle, which you deal with, affect the disease progression in these patients? And if they do, how what are your clinical pointers which will help us if we face similar scenario?
Very well question that this is almost a norm that our patients stop or decrease the drug dosages and they come back when they need it. So from being an expensive painkillers, we need to challenge it that these are disease modifying drugs and we need to adhere. So one of the questions that I always ask, is this patient going to take this medicine for a longer period of time? And that question needs to be addressed at upfront. So I ask myself, is he going to adhere? What are the barriers of his adherence? So if there is a barrier of adherence, then probably there's one chance that I would use a JAK inhibitor because you don't get anti-drug antibody. We're not concerned about anti-drug antibody only in SpA. We are also concerned in other conditions also. So one of the idea is that why to start a biological if they can't take up the burden and take it for a longer period of time. And if they start and stop, that is the norm. I think we have data to suggest that the least anti-drug antibody forming agents would be etanercept or golimumab rather than adalimumab or infliximab. So that's one thing, but that's not the most important question. The question is how to ensure. So what one can do, which is an answered question, which I had highlighted, can we switch? So if we have got a good control with anti-TNF, can I think and discuss with the patient? So, and I know that burden is there. Can I go to JAK inhibitors and see? So transiting from a biological drug to a targeted therapy, that is one of the ways one can circumvent this start and the stop business.
Thank you. And one for Nigil. So are there any IL-10 signatures seen in ANG-SPONT? And because there is some data, I believe, in IBD related to that. And then also that do you see a lot of gut lesions, similar gut lesions in ankylosing spondylitis?
Great question. So IL-10 is interesting. So I think whoever asked that question about IL-10 is probably connecting the IL-10, IL-20 role in gut homeostasis and mucosal immune system. So it's a key molecule that is involved there. If you look at AxSpA serum and tissues, there is an increase in IL-10 signature. So I have always believed that that signature is probably a response to the significant inflammation, because IL-10 has protective roles in the immune system as well. So I've always seen it as a response. I've not thought about it as being pathogenic, and whether that is key. Now, if you bring down, I don't know if by treating with IL-17 you get a lower IL-10 signature leading to gut inflammation, or I don't know that connection. I don't think anybody has really explored that. But yes, you do have a significant gut involvement microscopically in AS patients. 60-70% have some form of gut inflammation. 10% have overt IBD. So definitely clinically there is a strong connection. I'm not sure it is related to IL-10. I don't think there is data on that. Yeah.
Fantastic. And then we have a few questions related to JAK inhibitors. One is that for the non-responders or decreased efficacy scenarios in patients who are on JAK inhibitors such as tofacitinib, is there any sort of evidence to suggest that increasing the dose to 10 milligram twice daily? So it's so people who are on 10 milligram daily, just doubling the dose. Is there any data to support, or is there sort of any logic to support that? Your experience, if any?
Nigel has the data driven thought process,
Yes.
and mine is a practical driven. So if we
Okay,
can
so
go,
we go for practical first and then Nigel, yeah. Okay.
10 milligram BD is what we think for ulcerative colitis or a bad psoriatic arthritis. So if it is equally bad, poor response, that was one question that I had when I discussed poor response. So can I use a 10 milligram BD? I would definitely do, but there's a risk of more thromboembolism, and a risk of getting more infections, say herpes. So in a younger population, yes, I would do it, but not in elderly population. 10 milligram BD in elderly population, say a diabetic with 45 years of age and has a not poor response to tofacitinib 5 milligram BD, I will not hike to 10 milligram BD. I may think of the other agent. But the young boy, 22, yes, I may take it. I may take it. That's my practical view.
Nigel, your comments?
Yeah, so we hesitate quite a bit from going higher because obviously of the side effects, right? And you know that the higher dose was more likely to cause the vein thrombosis and potentially increase cardiovascular. So we hesitate. But our IBD colleagues, the GI physicians, definitely use much higher doses, and we have seen that it significantly improves the gut inflammation. Does it improve the joint inflammation? Perhaps, but I'm not sure. If you look at 100 patients on similar doses, you will see a significant difference as a group. Individual patients, yes, I agree. You may want to try, especially if you have partial response and nothing else works. But I'm always worried, especially if the patient has risk factors for cardiovascular events in the future. I always worry. Yeah.
Great, thank you. And I think just last couple of questions. One is a real practical one. So the latent tuberculosis infection is a big problem for us, and of course with the immigration, migrating population, tourism, and all that. Probably this is a group of patients you also see a lot. So as far as you are aware, are there any sort of biomarkers either available or in development which will help us with this troubling clinical scenarios? Ajay.
Yeah, probably Bimlesh would have more idea. At least on our side, we have still been following the standard of practice. If there is any doubt, we have a TB clinic that specifically looks at immunosuppressed patients, and even from that group, we have not seen anything specific. The the most sophisticated test we do in this population is an IGRA. That is the most sophisticated we get to. So. It's generally just the TB skin test, and you do the IGRA where required. Nothing else here. Yeah.
Your comments, Bimlesh?
So the screening protocol has to be there. There's no doubt about that. One cannot say that tofacitinib being a cheaper molecule does not require the stringency of what you do with the biology. So you have to conclude that. And if there's a risk and there's a latent TB, I would definitely give isoniazid. There would be questions asked that you increase the risk of resistance, but still I cannot give a tofacitinib with rifampicin which is available. So rifampicin and INH do not, so your arsenics do not go with your patients. It has to be INH. And we don't have rifampicin. So that's the problem that we have. And prophylaxis is very, very important. Recently, we published a series of cases where we had extrapulmonary tuberculosis, 4 in this skeletal and 1 was pleural. And that was eye-opener despite doing the stringency and despite looking into data of the tofacitinib in RA population, which was next to a few odd cases in their studies. Our group itself had 6 patients well established biopsy-proven tuberculosis of the extrapulmonary, here the pot spine. So that actually gives an idea that it is not as safe as what we believe based on only on the data that we had from the studies of tofacitinib and extension studies. So we are very careful about as the TB or any other infection with tofacitinib. And it has happened with the younger population too. So it's not the age where we can say it's elderly population, you can have it in the younger population.
Thank you. And Nigil, the final question of this session to you. Of the new agents you have discussed in your talk today, is there or are there any, good or promising agents or sort of, evidence which works better for uveitis associated with SPA?
Yeah, the standard of practice that we have followed over the years has not changed when there is uveitis with AS. Yes, the new agent bimekizumab looks interesting because maybe there is a less risk of a flare when you use bimekizumab. I don't think I will propose it as a treatment of uveitis yet. It's just interesting data where you didn't see a lot of flares happening. First of all, even that little interest has to be kept alive by validating the studies. We are very, very far from proposing that as a treatment of uveitis. So the uveitis has to be treated with a monoclonal TNF inhibitor in AxSpA patients as of now.
Thank you. And I'm sorry that because of the lack of time, we are unable to take more questions. But probably, I request Abbott team to follow up these questions and put to our speakers through email because I think that they are really interesting questions just because of the paucity of time. So I would like to thank Dr. Bimlesh Pandey for his grounded talk and very informative, and Dr. Nigil taking us through really what is new and sort of in terms of research, our understanding of pathogenesis, particularly personally, as I said, the window of opportunity, discontinuing biologics, and your recent insights into the HLA-B27 were really, really interesting. So, so thank you very much, and I hand it over to Dr. Yogesh. Thank you.
Thank you so much, Dr. Vinod. And as we draw our first virtual international speaker program to a close, it is my honor to extend a vote of thanks on behalf of Abbott and Indian Rheumatology Association. Firstly, I would like to thank the esteemed panel who shared their invaluable insights and research experience to the entire Indian Rheumatology fraternity. Thank you for your time, efforts, and all the effort that you put in your presentation was seen, right? And to our participants, I'm extending a very, thank you for active engagement and thought-provoking questions. All these questions were quite novel and we had a very informative sessions, I would say, and beneficial for the clinical practice, right? And last but not the least, a special thank you to the team IRA, eConnect, where they were supportive and collaborative. And your partnership has been instrumental in executing this kind of program and fostering an environment of professional and learning growth. So we would conduct more such sessions with more international speakers in the month of September and November. So I would urge everybody to actively participate in such kind of programs. And with that note, I take we we take a leave, and thank you so much for your time and patient listening. Thank you so much.
Thank you, everyone. Thank you. Good night.
Bye.
Thank you.
Thank you, Nigel. Thank you, Dr. Pandey.